Welcome to Medical Specialists Associates Educational Series on Critical Care Medicine. I'm Christopher Voss, MD, MS, FCCP, board certified in Anesthesiology, Critical Care Medicine, Neurocritical Care Medicine, and Critical Care Echocardiography. Today we will address a critical and often overlooked issue in the management of sepsis and septic shock: fluid overload. Despite our best intentions to resuscitate patients effectively, there is a dangerous practice that can result in significant harm: excessive and unchecked fluid administration. This talk will delve into the phenomenon often referred to as set and forget, where physicians initiate fluid therapy but fail to adequately reassess and manage ongoing fluid needs, leading to iatrogenic fluid overload and associated complications. Pathophysiology of fluid overload in sepsis. In the early stages of sepsis, aggressive fluid resuscitation is necessary to restore intravascular volume, support cardiac output, and improve tissue perfusion. However, the pathophysiological landscape changes as the septic response evolves. During this transition, continued high-volume fluid administration can lead to capillary leak syndrome. As endothelial integrity is compromised, fluids extravasate into the interstitial space, leading to tissue edema and hypoxia despite adequate or excessive intravascular volume. Interstitial edema. The excessive interstitial fluid accumulation, particularly in the lungs, can exacerbate respiratory failure and impair oxygenation, leading to acute respiratory distress syndrome. Organ dysfunction. Fluid overload contributes to renal congestion, hepatic dysfunction, and gastrointestinal edema, further complicating the clinical picture and increasing the risk of multi-organ failure. The set and forget phenomenon. The set and forget approach in fluid management refers to the initiation of fluid therapy without subsequent reassessment or modification, often resulting in a positive fluid balance that is detrimental to patient outcomes. This practice is dangerous because it ignores the dynamic nature of sepsis and the body's changing fluid requirements. The failure to adjust fluid therapy in response to the patient's evolving condition can lead to several adverse outcomes. Increased mortality. Positive fluid balance has been independently associated with increased mortality in critically ill patients, particularly in those with sepsis and septic shock prolonged mechanical ventilation. Excessive fluid can exacerbate pulmonary edema, necessitating longer periods of mechanical ventilation and increasing the risk of ventilator-associated complications. Delayed recovery. Fluid overload has been linked to prolonged ICU stays and delayed recovery, further burdening the healthcare system and increasing the risk of long-term complications. Evidence against fluid overload. Several studies highlight the risks associated with fluid overload in septic patients and support a more conservative or actively managed approach. 1. Silversides et al., 2018. This study demonstrated that a positive fluid balance on day 3 of ICU stay is strongly associated with increased mortality. Conversely, achieving a negative fluid balance through deresuscitative measures was associated with improved survival rates. The study emphasizes the importance of reassessing fluid needs and actively managing fluid balance to optimize patient outcomes. 2. Payen et al., 2008. This research found that patients with acute renal failure and positive fluid balance had worse outcomes, underscoring the critical need to monitor and control fluid administration in critically ill patients. 3. Wiedemann et al., 2006. The study compared conservative versus liberal fluid management strategies in patients with acute lung injury, finding that conservative fluid management improved lung function and reduced the duration of mechanical ventilation. Recommendations for fluid management in sepsis. Effective fluid management in sepsis and septic shock involves continuous reassessment and adjustment based on dynamic assessments that provide real-time feedback on the patient's fluid status. The following strategies and tools can be utilized. 1. Frequent reassessment of fluid status. Utilize dynamic assessments to guide fluid therapy. These include passive leg raise test, a reversible method to assess fluid responsiveness by simulating a fluid bolus through venous return increase. Stroke volume variation. Measures. Variations in stroke volume during the respiratory cycle in mechanically ventilated patients, with higher variability indicating fluid responsiveness. Pulse pressure variation assesses variations in pulse pressure during the respiratory cycle, helping to predict fluid responsiveness. Inferior vena cava ultrasound assesses IVC diameter and its variation with respiration, which correlates with fluid status. End expiratory occlusion test temporarily stops mechanical ventilation at end expiration to assess the response of stroke volume to increased preload. Echocardiographic assessment of cardiac output directly measures cardiac output and stroke volume, providing insights into fluid responsiveness. Lactate clearance monitors the clearance of lactate levels over time as an indirect marker of tissue perfusion and fluid resuscitation effectiveness. Cardiac output monitoring devices advanced hemodynamic monitoring systems for continuous assessment of cardiac output and dynamic indices like stroke volume variation and pulse pressure variation. Capnography, end tidal CO2 monitoring, measures changes in end tidal CO2 monitoring as an indirect indicator of fluid responsiveness. Venous to arterial carbon dioxide gap reflects the adequacy of cardiac output relative to tissue oxygen demand. 2. Deresuscitation. Once the initial resuscitative phase is over and the patient is hemodynamically stable, consider strategies for fluid removal, such as diuretics or renal replacement therapy. This approach, known as deresuscitation, helps mitigate the effects of fluid overload. 3. Conservative fluid strategy. Implement a conservative approach to fluid management, particularly after the initial resuscitation phase. Limiting maintenance fluids and carefully titrating ongoing fluid therapy can help avoid unnecessary fluid accumulation. 4. Use of diuretics and renal replacement therapy. These should be considered when fluid overload is evident and contributing to organ dysfunction. The goal is to achieve a neutral or negative fluid balance to improve outcomes. Conclusion. Fluid management in sepsis and septic shock is a dynamic and critical component of care that requires continuous reassessment and adjustment. The set-and-forget approach to fluid administration is dangerous and can lead to significant patient harm, including increased mortality, prolonged mechanical ventilation, and extended ICU stays. By adopting a more conservative and actively managed approach to fluid therapy, critical care providers can significantly improve patient outcomes in sepsis and septic shock. To learn more about critical care medicine, visit us on our website at www.medspecialists.net and subscribe to our YouTube channel.